wait for a little bit, I think 2 more minutes, and we can start. Distracting by any phone calls and alarm from phone calls, from telephones is really distracting to everybody. Just want to formal discussion. We'll ask one question. We know in Turkey it's usually difficult to have Turkish language and Arabic language. So how come, mashallah, tabarakallah, you know Turkish, English, mashallah. How come you know Turkish, English, Italian and French? How come?
I studied
Isn't it unusual?
For example, I studied Italian. I finished 5 classes. Because at the last year of the university, medical school, let's say, I wanted to go abroad and start plastic surgery in Italy. So I finished 5 classes, and also there is a general exam in Turkey. I passed the general exam, so I couldn't go to Italy, but I became a plastic surgeon in Turkey.
Yes,
because I passed the general exam. So Italian remained to me. French is from high school. For 4 years in the high school, I learned French as a secondary language. And my secondary school, primary school, and high school was an English school. Every lesson was in English, so English is my primary language.
I see, that's
so maybe I'm a little talented because I work in Finland, also I work in Portugal. I speak a little Portuguese and Finnish also.
Wow, this is very impressive.
And also to educate my son, I speak a little German.
Wow, that's very impressive. 6 languages, that's a lot. By the way, do you know when an average person dies, how much brain cells have he used? The average person, how much did we use when an average person dies? We use less than 10% of our brain cells. But language or multilinguistic is one of the reasons that keeps our brain cells works more and more. So this is really very smart of you. Very impressive. Please, if you can close the doors. Okay, the question is, Bismillah ar-Rahman ar-Rahim. It's my pleasure to introduce a well-known professor in Turkey and also in Europe. I'll talk about him, introduce him in a minute, after 1 minute. But the question is, until when we're going to do the aesthetic medicine by just botulinum toxin and fillers? Until when? We have done enough. Most of you have done hundreds of fillers, hundreds of botulinum toxin, but until when? Now is the time that we look. Botulinum toxin is for muscles, fillers is just to replenish or to augment some areas, but now we have to work on the workhorse. The workhorse in our beauty is collagen. It's not the muscles. The art is not just to flatten the muscles and remove the expressions. The art is to improve from within. And the way to do it is to work in collagen. I'll show you one slide that has actually now become more popular. No, that's not popular. I went to the end, I guess. Yeah, I'm sure everybody knows what's this. Let me just summarize what I just talked about a minute ago. إلى متى احنا نشتغل فقط على العضلات ونعوض الأنسجة بحقن التعبئة اللي هي أكثر شيء الهيالورونيك أسيد؟ إلى متى؟ ما هو النجاح في التجميل إنه بس فقط احنا نشيل العضلات وننفخ مناطق ونعبي مناطق ونكبر مناطق؟ مو هذا هو الهدف، إن احنا نبقى في هذا المستوى من التجميل. التجميل هو لازم نروح إلى الأساس في جمال البشرة، في جمال وجهها، وهو الكولاجين. الكولاجين هو الورك هورس اللي يعطينا نضارة، يحافظ لنا على شد البشرة، يقوي بشرتنا ويعطينا ملامح جميلة، وبالتالي ممكن تكون أصغر أو أنظر من باب النظارة. أكيد معظمكم يعرف هذا الشيء. مؤخرا النانو فات أصبح ورك هورس بالنسبة لنا احنا. مع شد الوجه بنسوي نانو فات، مع شد الصدر بنسوي نانو فات، مع تجميل اليد بنسوي نانو فات، مع الجفون بنسوي فات، مع الرقبة بنسوي فات. لكن nano fat is not very easy to take from everybody you take fat from. It's a procedure, it's a surgical procedure. It's nice, it gives you safe results, you have almost nil side effects, but the act of surgical procedure is not really acceptable by every person. الإجراء الجراحي ما هو مقبول بسهولة لدى أي مريضة مراجعة لنا، ولا هو شيء سهل على أي مريضة. بعضهم يخاف من الإبرة، فما بالك لما تقول له بشرب منك دهون عشان أحسن لك نوع بشرتك. لذلك now there are alternatives. Now there are so much alternatives to work on the collagen synthesis, not only the muscles, not only the volume, not only the replenishing of the volume. الآن عندنا بديل يشتغل على تحفيز الكولاجين لشد البشرة، لتحسين البشرة، وبالتالي نحصل على جمال أفضل وأفضل. We have today Professor Aydin. He came from all the way from Turkey. As I told you, I was very impressed that he has 3 languages, but now apparently he has 6 languages almost, and this is very smart of him. Professor Aydin, he's a professor in Istanbul, Turkey. He has graduated from Turkey. He did his residency in Turkey, but he also did so many researches in McGill and Toronto, and believe it or not, he's an aesthetic, but he still practices so much spectral, maxillofacial, reconstructive, hand, peripheral nerve, aesthetic, as well as congenital defects. So really he has a lot on his shoulders to do and give to the community. ما يقتصر شغله فقط على التجميل، يمتد شغله إلى جراحة الوجه والفكين، الحروق، التشوهات الخلقية، الإصابات، الورم والترميم أيضا. يتميز بشهادات كثيرة. He has won many awards. One of them is from the European Society. He has close to 360 citations of his publications, which is close to 100. And this is really very impressive. As you know, citations has no bias. If there is citation, it's a good citation. He has practiced in Turkey for all this time. He is a trainer for so many companies. Some of them are threads, some of them are fillers, some of them, as you know now, is calcium hydroxylapatite. And this tells you if someone is willing to train, he's willing to teach, he's willing to give. Because some people, they have lots of knowledge, but they really don't have the time, they don't have the willing to give and teach. خرج من تركيا، سوى ريسيرش كثير مع كندا with a very and the States, Washington also, Susan McKinnon and Kerrigan. حصل على العديد من الجوائز، جزء منها جوائز داخل تركيا، جزء منها أوروبية. عنده كثير من الأبحاث، كثير من المنشورات الطبية. على الأقل عنده 360 حوالي 400 citations اللي هي الناس بيستخدموا منشوراته كمرجع أساسي في أبحاثهم القادمة. هذا شيء فعلا جميل جدا. يدرب لشركات كثيرة، جزء منها فيلرز، جزء منها إبر تابية، جزء منها هيدروكسيلاباتايد. With this one, we'd like all to enjoy listening to Professor Aydin. I'll be the moderator. If you have any questions in English, in Arabic, I'm willing, but no questions in Turkish because I can't understand.
Okay.
Professor Aydin.
Thank you very much. I stand in my lecture from the ground and in the front center. I would like to thank Dr. Ayman for this nice introduction. So what we do with the calcium hydroxyapatite fillers is also increasing and triggering the collagen synthesis. This is very, very important. Collagen maybe is the new product of the next decade, maybe next 2 decades. We are all trying to use new fillers for increasing the collagen amount in the subcutaneous tissue. So this is my short, let's say, working scheme or schedule. I would like to immediately start my lecture on Facetem fillers. I have been using Facetem calcium hydroxyapatite filler in the recent 1.5 years, and I'm very successful and very satisfied with this filler. This is a very nice filler. Also, I would like to recommend you because it has a different technology than the previous fillers, also the American brands. It has a lattice pore structure which protects the inside calcium hydroxyapatite core from dissolving. So usually, you know, calcium hydroxyapatite fillers dissolve within 12 to 18 months, but this will help Facetem to dissolve approximately approaching to 2 years. So you can easily use in every part of the face except the glabellar area and the lip area. And I will show you later in several areas. I recommend you to refrain from using Facetem filler because there are several dangerous areas, and this is not a hyaluronic acid. This is different. This is a semi-permanent filler. So it's a bioceramic hydroxyapatite has been for many years used for orthopedic surgery, craniofacial surgery, dentistry. Now, since 2000 years, since the beginning of millennium, let's say, it has been used as a filler. So it is almost before the hyaluronic acid era. But let me tell you that calcium hydroxyapatite is the booming filler in the, let's say, league of the fillers. Hyaluronic acid is the #1 filler, but calcium hydroxyapatite in the last 3 years is the most top seller, though it has low share in the market because almost everywhere. Universally, we have been using hyaluronic acid with good success, but in several areas, if you want to get more volume, more lifting effect, in suitable regions of the face, I would like to recommend you to use calcium hydroxyapatite filler, Facetem. So if we look at closely to the structure, electron microscopy investigation of the structure of Facetem. This is Facetem. This is the, you might recall, this is the famous previous American brand of the calcium hydroxyapatite. When in comparison, you will see the difference from the core structure, outside structure. This is, I'm sorry to, yeah. When you look, this is like iron Facetem filler. You might think of it fancy like layers and also like iron, but the previous American brands, calcium hydroxyapatite is three-dimensionally like sand. This is Facetem, this is the American brand sand-like structure. What is the difference? What difference it brings? It brings the late dissolving of the Facetem product when you compare it with the famous American brand. So this is the outside shell, let me tell you, shell of the Facetem, calcium hydroxyapatite filler. So this delays its dissolving, but it always, in other American brand, always has cell-like structure, so it dissolves approximately, also in scientific literature, 12 to 18 months. So it's a homogeneous microsphere. Another difference from the previous American brand, very famous brand, which has received FDA, but Facetem has a CE brand, CE approved. The average size of the microspheres of the Facetem is approximately 30 micrometer, but the American brand is approximately 25 micrometer. So it's a little bit bigger than, which means it can escape from phagocytosis more easily. So they both, as other calcium hydroxyapatite containing fillers, they all stimulate collagen, and also they stimulate collagen very in a high ratio when you compare it with hyaluronic acid containing fillers. So over time, after injection, it stimulates body's own collagen stimulation. Also, it helps the extracellular substance of the body. It increases elastin as well as the collagen. So collagen stimulation is an important feature of Facetem, and when you compare the collagens that it triggers, especially like other collagen calcium hydroxyapatite fillers, it stimulates collagen 1 and 3. But when it is, let's say, investigated deeply, it triggers collagen stimulation more better than the previous American brand of calcium hydroxyapatite fillers. So viscoelasticity is very important, you know, values G prime, G double prime, and also the theta values of the fillers. Facetem S is the 1.5 ml of Facetem, let's say. Facetem filler, calcium hydroxyapatite filler, is superior in every aspect of the comparison, with the complex viscosity, shear viscosity, and tan values and elasticity values are always higher than the American brand. So shortly, indications are almost in every part of the face: cheeks, temporal hollows, cheek, jaw area, nasolabial area, cheeks, temporal area, nose, forehead. I have been using in all regions of the face, but there are several contraindications. Let Vitaglio. Do not use in the glabellar area, infraorbital area, and lips. Ellipsis is certain complication because you know calcium hydroxyapatite containing fillers are whitish or dirty white in color, so also it's a little bit thicker, high G prime value. You cannot use it in lips, but if the patient has fantasies like porcelain lips, you can use, but it will be very unlikely to choose porcelain lips in female patients. Also in the glabellar area, it is very, very risky. Also hyaluronic acid is very risky. Also fat injections are very, very risky. So as long as you improve your experience, as long as you are very well versed with injection in glabellar area and in the nasal tip and the nasal dorsum, then you can use. But these are very, very dangerous places. These are the first and second top dangerous zones of the face, which might end up in blindness, visual impairment, and disasters. So please do not inject the glabellar area and the tip of the nose, dorsum of the nose. After you, it is not contraindicated. Generally, there are many good papers about usage of calcium hydroxyapatite for nasal contouring, but you have to make a good patient selection and you have to have good experience, good on this region. You have to study anatomy, but mainly for plastic surgeons and otolaryngologists or surgeons are mainly more, let's say, diehards, and they have more experience in anatomy and surgery of these fields. They can easily inject, but as long as you are not a surgeon, be very careful. For the infraorbital area, the skin is very thin. Also, you can have a different type of Tyndall sign, which is you will have whitish lines if you inject too much, if you inject too superficially in the infraorbital area, and it goes sometimes. There is also one case published in the literature. If you inject here, you will have a xanthelasma reaction. Whitish and also the later yellowish color you will have, and it will be very difficult to get rid of this in this area. Please reserve this area to hyaluronic acid injections. I recommend you. In one case, I injected a calcium hydroxyapatite filler. There was a whitish superficial color in the infraorbital region that I injected. Though I injected over the periosteum, I think there is some migration of the filler. So I was able to get rid of this whitish color with 2 sessions of cortisone, triamcinolone injections. Then I got rid of them, but you might not be that much lucky. So it's better to use to inject calcium hydroxyapatite for increasing malar projection in the close vicinity of this area. Also for the forehead, you can also inject, but we haven't included forehead for you to inject because in the forehead you have to be supraperiosteally over the periosteum deep. Also, it is risky, but the glabellar area, the midline, this part is very, very risky. So in the forehead area, the lateral sides of the forehead is not that much risky, but you should revert it to later, let's say, injections after you have increased your experience in relatively easy areas. Then you will do injections with a cannula. Certainly with a cannula in the forehead area. You might also dilute calcium hydroxyapatite with good success in the body and in the face. For the hand, one-to-one dilution is okay, but let me tell you, these are key remarks. When you dilute the semi-permanent fillers, for example, such as calcium hydroxyapatite, the volumization effect will decrease, also lifting effect will decrease. So, if you dilute it too much, then you will be approaching like a mesotherapy. Yeah, somehow it will be somehow like a mesotherapy. But in the neck area, dilution with 1-to-1 or 1-to-4 is good idea, because if you inject directly, in some patients you can have white lines, white transverse lines in the neck. So you have to be very careful and superficial. You have to, it's better, I recommend you to use cannulas in the neck, and you have to inject superficially, then inject too much, you can have lumps. We call it beading, and also finally white lines. So the patient will be troubled about this injection. But don't worry, like hyaluronidase for hyaluronic acid, you will be thinking or troubled about, is there an antidote for calcium hydroxyapatite? Yes, there is. There are two manures. Also, one recently published article in Aesthetic Surgery Journal. So I will tell and show you about these articles. So for dilution, you can dilute with lidocaine or dilute with sterile saline. It's not that difficult. I will also show you the dilution. But in skin where, for example, in the neck skin or in the hands or in the décolleté area, you can dilute from 1 to 2 or 1 to 4. There will be no problem. You will get a very good result. Also, with dilution in the face, for example, you will get like a mesotherapy effect. The skin will be shining more tight, and you will get a better skin rejuvenation, because you must know that somehow you are also triggering collagen synthesis. So, as a conclusion, calcium hydroxyapatite containing Facetem, 30% it contains, and the other parts of the Facetem is standard carboxymethylcellulose as hyaluronic acid. This is the carrier material which will be totally resorbed by the body within 6 to 8 weeks. Glycerin and water. Glycerin also moisturizes the skin. Water is the natural constituent of all fillers with a small percentage. So microsquare size is 25 to 30 micrometers. Approximately its average is 30 micrometers. Injection area is deep dermis. And in the chin region, in the forehead region, and in the malar region, over the zygomatic bone, you can inject over the bone, but do not inject superficially. This is not hyaluronic acid. You should in several areas. For example, in the temporal area, you can also inject. It is not contraindicated, but inject the superficial subcutaneous tissue, deep dermis. So, for injection, I always recommend you to use in the forehead area, cannula. In the temporal area, use cannula, blunt cannulas. Also, in the jaw, it's better to use cannulas. In the nose, you can use cannulas, but it will be difficult. So, learn how to inject nose in later sessions of your life. In the malar region, you again use cannula. It is better on the periosteal to be on the safe side, because you know there are several dangerous roads in the face. You have to be always on the safe side while you are injecting. Also in the nasolabial fold, you can use inferior ports. You can open small holes. I will show you with the videos. This is not all theoretical and boring lecture. Don't worry, now we'll start the action soon. Also use in the nasolabial area, you can use needles or you can use cannulas. It's better to use blunt cannulas with lower entries. In the marionette area also you can get very good filler effect and also a lifting effect with calcium hydroxyapatite containing Facetem filler. So these are my conclusions. Facetem is good volumization for lifting. It's a collagen booster. As a summary, elastic booster. Also, it enhances osteogenesis if you inject deep on periosteum. It has been proven in orthopedic and craniofacial surgical operations and also experimentally. Also in the jaw region, a Chinese article recently showed that if you inject over the jaw region, it enhances bone production. If you dilute it, it's a skin booster. It has a very good tightening effect, and it has a longevity lasting approximately to 24 months. It is natural, biocompatible, it is non-allergic. Also, it has very low risk of complications, you will see. And let me tell you the main problem with the complications. If in semi-permanent fillers like Facetem, you have to do threading whenever you inject with small amounts. If you do pulling, what it means, if you enter somewhere and push most of the filler, it will cause a pull under the skin. So you will end up with the nodules and granulomas. So do small thread lines under the skin. It is very important. And its antidote is, you will see sodium thiosulfide. If there are any dermatologists inside of you, dermatologists will know that it's the treatment of carcinosis cutis. Calcification of the skin. It is used systemically and also it is used as an intralesional injection treatment. But you have to inject small amounts and you have to inject 4% thiosulfide, sodium thiosulfide. I will show the details later and the scientific articles. So this is an article about the use of Facetem implant, Facetem filler, that it increases experimental collagen elastin 5 times than the control product, which is the American product. And also, inshallah, I'm writing now in my 1.5 year experience on Facetem fillers on various parts of the face. Then next year, inshallah, we will all read this article of mine. This is another article. Facetem has been used by otorhinolaryngologists for enhancing outcome injection laryngoplasty, and it says it's superior when you compare it with the other filler, American filler. So this is a very, very good article in Dermatological Surgery Journal on a degradation of calcium hydroxyapatite. When you think that you have injected excessive amount of calcium hydroxyapatite, you can easily dissolve. But the treatments are all about injection treatments, dissolving plus dispersing. For example, assuming like a collection of calcium hydroxyapatite underneath the skin, you are dispersing the microspheres with injections. Then it is easily absorbed by the body. So this is about another article. This article shows the guidelines, a very recent article, guidelines about the dilution of calcium hydroxyapatite you can use in all parts of the body. So these are as a summary in each part of the face. You can use neck. Also, I haven't used in the armpits or arms. I have used in legs. Also around the knees, you can use it with success. You have to be careful in the lateral sides of the knees, but otherwise the other part of the knees and also around the patella, you can, under local anesthesia, inject and you can get very good knee rejuvenation. So also in the body, calcium hydroxyapatite has been used with success to elevate the scars. So we get to the action now. These are the clinical cases of mine. First, in a case, I show the previous situation of the patient. We are starting for the nasolabial folds. The patient is under local anesthesia. In every patient, I draw the area that I will inject Facetem with a makeup pen because it's easy to remove, white makeup pen. The patient is injected with lidocaine plus epinephrine, approximately a total of 2 to 3 ml. Then I wait for 15 minutes without doing anything. Then through a lower port that I open with an 18 gauge needle, I mainly use cannulas, but you can use needles to be more precise in this area.
Dr. Adel, is this already diluted or as
non-diluted? In the face for correction, getting volume and lifting effect in the face. In nasolabial fold, I do not dilute it. There will be no problem. You can directly inject.
As I see the needle, it's coming almost touching the dermis from inside.
Yeah, because
like
to get a better feeling, you have to be superficial a little, and also if you follow up the trace of the facial artery, you have to be superficial here. You have to be deep here.
Yeah,
this part you have to be deep. This part you have to be superficial.
My worry now is not about the vascular accent. My worry is about what I hear about the nodules formation after the calcium, if it is that superficial without dilution. But that's what you recommend?
It's better to do, but let me tell you, for 1 or 2 months after injection, the patient might feel small lumps underneath the skin. Then after that, it will be over, it will be flat. There will be no problem, don't worry about this. Because we cannot inject over the bone, we have to be over the muscle, but subcutaneous plane we have to be.
So now this indication is out of under the filler technique as not device stimulation. As a filler.
Linear
subdermal.
The subdermal, yes.
Okay, by the way, the floor is open for any questions. If anybody has any question, please jump in and let me know. Please go ahead, Doctor.
This is the before and after of the same patient, 30 days after. You very well feeling the effect of the Facetem filler. Also, it's hard to get rid of these wrist of space. This is a preferred triangle, but it's a very good and satisfactory result for the patient. So this is another patient, second patient. She is aged a little bit more than the previous patient. Before and after photo of the patient. Again, I have used total of 1.5 ml divided into two sides. I used cannula, lower entry. This is another patient. This is a younger patient. She is about, I think she was 35 or 36. But this is not a difficult case. You see, these are not deep. There are several grooves here in the lateral sides. From my point of view, it's hard to correct this in one session because they are deep grooves now. But you see, very satisfactory result in this patient. For the nasolabial folds, we do not have too much problem, but in these areas, the patient was mainly troubled with lateral parts of the face.
There is two questions.
Sure.
I am Dr. Islam Kayali, consulting plastic surgery. You said there is antidote, sodium thiosulfate.
Sodium thiosulfate.
Is it in practice? You start working on this antidote because it's not available in Saudi Arabia. Have you ever used it?
I didn't need use because I always injected thread lifting technique. I injected small amounts and also I always taught half the hyaluronic acid dose when I inject it.
I agree. In case you need to use it, is it available in?
It is available in Turkey because it's a merged chemistry compound. Merged.
But you are working and it's...
also it has been used with dermatologists for getting rid of carcinosis cutis reactions in the skin, in clinical.
Second question, you said calcium hydroxyapatite enhances in some areas.
But in the, for example, jawline area,
You like?
if you go deep onto the in the chin area, I recommend you to inject over the bone because if you are superficial, you can inject over mental muscle or depressor muscle. We don't want to inject into the muscle. But in the lateral jawline, it is wise to be superficial in the subcutaneous tissue. If you go deep, you can injure facial artery and marginal mandibular nerve. If you inject over the bone, try to inject over the bone in over the masseter muscle or in the back, you can injure parotid gland, you can injure also the marginal mandibular. So this injection over the bone is only valid in the chin area, in the bone area, nasal bone. And in the forehead, you try to inject over the supraperiosteum.
I agree with Dr. Ayman. Main problem of calcium hydroxyapatite filler that it's thick filler, nodules. So to inject pure calcium hydroxyapatite subdermal, maybe it will give nodules. Do you advise if we dilute it better?
In the face, you don't need to dilute. In the neck, you better dilute. Maybe you will ask, I'm reading your mind. For example, I inject to the nasal area and the patient went to X-ray. What happens? Studies have studied. You know famous Carruthers from Canada, Carruthers. He has made the radiological follow-up of all the patients who had undergone calcium hydroxyapatite fillers. Approximately among 60 patients, only in one patient there was some blurring in the face, otherwise there was no problem. And recently there is another paper on the if there is an interference with the radiological diagnosis of calcium hydroxyapatite when the patient X-ray or tomography. So it says it's totally innocent, there is no problem. It's an American paper. These are two papers. Sorry? In only one patient it was found opaque, radio opaque. Otherwise it was not consistent. These are American papers also. Let me tell you that there are several journals from my point of view which are not that much good. Let's say that not too scientific, but these two papers are published as scientific papers. If you want, maybe I can send you these papers. Okay.
Dr. Hafsa, plastic and reconstructive surgery. Regarding the osteogenesis effect of calcium hydroxide, you show a picture of calcium bolus over the bone at the piriform apparatus. So regarding cleft lip nasal deformity, we know there is defect at the piriform apparatus. Can we use it to elevate the hyperplasia of the left side? Or
In the
it's
cleft
not
nose,
solid?
you mean? Cleft
Cleft lip
nose.
nose, yeah.
Yeah, it can be used in to elevate here in the deep area of the, let's say, maxilla. It's safe to inject here if you go deeper. If you inject superficially, you can inject columellar artery, branch of angular or superior labial artery. But it's safe, you can use.
Yes, we can use it and inject deeply over the bone. So, is there any study that causes osteogenesis and decrease the defect of the maxilla? Or
In fact, this is somehow previously, as a, let's say, pate, it has been used as small amounts for filling mandibular defects, calcium hydroxide in orthodontic surgery, in dental surgery. But this is a filler, so it cannot be used to fill bone defects if you are asking this.
I know it won't, but you said it causes osteogenesis, so.
Sure, it does not cause osteogenesis. When it is injected over the bone, it increases osteogenesis.
Not fill the gap. Increases.
But this is not a stem cell, you know, there is osteoclastic activity also as well as osteoclastic activity. So the bone will not, in approximately, since it has calcium hydroxide apatite received FDA clearance since 2000, now we are 23 years after, and there is no case that has shown that calcium hydroxide apatite has increased bone formation wherever it is injected.
But
It's not a stem cell.
it will last its effect of filling or
Maximum 2 years.
For 2 years.
But on average, from my point of view, 18 months. But it lasts longer than hyaluronic acid for sure. So this is another case which has a little bit deeper nasolabial force. Maybe it's class 2 when in the MERS scale, you know, there is a very good classifications of MERS for nasolabial force and also for example, false air part of the face. So this is the needle injection. This is the same case. This is the patient is again under local anesthesia. Now you will see. This is needle injection. In this part, you have to be deep. Below the modulus, you have to be superficial because facial artery is coming from deep to superficial. When it approaches the lateral ala of the nasal nose, then it becomes angular artery. From my point of view, using blunt cannulas are safer, and this is to augment the corner of the mouth. You know, there is reverse imaging in some patients. When you inject a little bit more superficially to the corner of the mouth, to the modulus or the lower lip, you lift up the lower lip, lateral side of the lower lip, and you try to reverse imaging. And you will ask why you are asking, for example, thinking I am injecting local anesthesia to the region and waiting for 15 minutes because I want to shrink the vessels. Also rendering the patient numb. Also I want to shrink the vessels so that the incidence of bleeding or God protect all of us, Allah protect all of us against embolization of the patients. So when the vessels are shrinked, and if you are lucky, let's say, you will get rid of any embolization. This nasolabial area is risky when the facial artery becomes angular artery, and when the branches of angular artery here anastomos with the branches of ophthalmic artery, but with shrinking of the vessels in this area, you will get very good results, no pain, and also, mashallah, I had no adverse event of embolization. I only had one adverse event in this area, but with polycarpolactone filler, as you might know, the other polycarpolactone filler, Sinclair's, Elancin. So I marked the patient. Again, the patient is done. This patient has a different history. Let me show you. This patient had been injected with fat injections before me, but the doctor has not evenly distributed fat injections, and this is nice OG curve, but in this part, OG curve is disrupted here, you see? So fat injection was not done evenly. Here you see nice OG curve, here the curve is disrupted. So she came to me for the correction of this. That's why I'm injecting calcium hydroxyapatite Facetem filler here, and also in this area. There is a depression in the lower cheek area here. I use blunt cannulas, 25 gauge. Why I am a little bit forced to push the cannula? Because of injections or because of fat injections, usually malar area, cheek area, in the nasolabial area, you will encounter fibrosis in every patient. It will be difficult to inject anything, or if it will be a little bit difficult to do thread lifting. If you are doing thread lifting in these areas, it's a little bit difficult, so you have to open up or make small tunnels. It can be called thread tunnelization with the cannulas, then you inject. So in all previously injected patients, whatever, if it is fat or if it is a filler, it will be a little bit difficult to inject. I try to do many small lines, threading. You see, it's hard to push inside. And you have to be horizontal to the skin surface. If you go deep, there lies the buccal nerve here underneath, going horizontally. And it's superficial after it has emerged from the masseter muscles edge here. You see, there's some difficulty to make threads inside. Thread fanning technique or thread linear thread technique. I'm trying to dissect or to do a little dissection with the cannula. So I usually use lower ports to enter.
I'm just going to ask just a question, just to get the attention of people. How many people in the audience inject calcium hydroxylapatite, regardless of the brand, without mixing? Without mixing? Subcutaneous or on the bone? Subcutaneous, 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 subcutaneous. Okay, about 10%. What do you tell your patients they are going to notice? Volume or skin quality improvement? Both. So you inject without mixing. Okay, interesting. Okay, well, as you see, Doctor, the majority do not inject calcium hydroxylapatite, regardless of the brand, without mixing. So this is something really very new. So we are exploring a new indication of calcium hydroxylapatite that's very new to most of us in this audience. I'm not sure about the other people who are outside the room or not. Now, the people who have injected this, of course, he's a professor, he has seen a lot. But have you encountered any nodules? How about the first month? As the professor mentioned that for the first month they would feel the nodules. Have you seen any nodules? Because we are almost banned from using calcium hydroxylapatite as a subdermal filler without mixing. Now we have something new. So we would like to reinforce that there is something new in the neighborhood now. There is something good in our table. There is something good in our hands that we have to utilize and offer to patients.
Okay, thank you. So if you even check, for example, since 2000, since the beginning of millennium, there are many articles on the use of calcium hydroxylapatite, because this is the first pioneer of calcium hydroxylapatite now and then it was an American brand. You can read many articles of calcium hydroxyapatite applications on the face without diluting, with nothing. But recently, to decrease the pain, the American company has produced calcium hydroxyapatite plus lidocaine. But also, for example, you can find in dermatological surgery journal, it's a really well-established, well-known journal, respected scientific journal from my point of view. If you dilute, for example, 10% of the, for example, 1.5 ml of calcium hydroxyapatite with 0.15 ml of lidocaine, the lifting and volumization effect decreases 17%. So, you can dilute to decrease the pain. Second thing is you can apply lidocaine cream and wait for 30 to 40 minutes and inject to the lidocaine to the entry holes here that you will open for the cannula insertion. Third is my way. This is local anesthesia. When you shrink the vessels, lidocaine plus epinephrine. Approximately with very small amounts you can do this, but you don't need to dilute calcium hydroxide. You don't need to get effect. First of all, this is not polycarbonato filler. This is not very solid. For example, if you inject to this area, or to nasolabial fold, if you're a novice, for example, in the chin area, with your finger, you can evenly distribute the product. You can do molding. You can mold. Don't worry about this. Okay? So you don't need to dilute. If you dilute too much, you will lose the lifting effect and the volumization effect. But in the neck, in the body, and in the hands, you have to dilute. It's better. Sure. No, I don't dilute. I inject lidocaine. I wait for 50 minutes. 2 to 3 ml total. I inject, wait for 50 minutes, then the body absorbs, then the swelling goes, then I start injecting. So I'm not mixing it with lidocaine. Okay? And for example, according to your question, for example, what is here? There is mental nerve here, isn't it? As long as you're asking. You can do nerve blocks here, mental nerve block, infraorbital nerve block. For the forehead, you can do supraorbital nerve blocks. So you don't dilute it. It's so easy. You don't mix with calcium hydroxyapatite. Okay? So for the marionette lines, you can get very reasonable results. But this is a younger patient. But also, I would like to draw your attention to the malar projection, which I will show later. In this patient also, you see also for the jawline injection, you see the shape of the chin and also the jawline in this patient.
Doctor, please, if you go back to one slide. Like for the cheeks area, how many mLs did you need to improve the cheeks?
For the cheeks?
Yeah.
I evenly distributed 0.75, 0.75, 1.5 ml to divided to each side.
And in this case, was the injection on the bone or under the skin?
On the bone here. You should inject over the periosteum. There are two entry sites. You can enter from here over the zygomatic bone. You can also enter through the nasolabial fold. The third one is you can also enter through the cheeks. There are 3 entry sites.
But the level of injection?
They will always supraperiosteal. There is only one thing to injure. If you go 1 centimeter below, here is infraorbital nerve and neurovascular bundle. If you go towards this, you can injure. And I will show you later, in the complications case, you can have ischemia in this region, but it will be over, don't worry. But you should be careful. I will show you how to inject to the malar region. I always use Hinderer's lines for injecting in the malar region to get a good malar projection. You know, Ulrich Hinderer is very famous. Okay. Yes. Yeah. They are detected. No. So I will show you in the malar region how to get very good results, my philosophy. And this is also another case. This is an elder case. You see the areas whitish. This is not ischemia. This is due to lidocaine plus epinephrine. You say, how do you decide that this is ischemia or not, for example? The patient will not have pain, this is tricky when you inject. But I use cannula, for example. In this patient, I do the aspiration test, but these are not guarantees. Also, I keep the patient after the procedure for some time. I also telephone the patient at night or the other day, send me a photo of your face in daylight. Then I want to see the color of the skin. This is very important. So you can, to be on the safe side, work with the lidocaine cream, which contains 8% lidocaine, but if this is too low, the patient will feel somehow a little bit pain, but that will not be excessive. With local, but also with vocal anesthesia, you can get very good results, to be on the safe side. So for the marionette lines, also, this is another case of mine. Again, she is injected with local anesthesia. I drew the area of the marionette lines. I again use cannula here. I do the thread, fanning and thread, linear threading technique. Let me warn you, in some patients you can end up with ecchymosis in this area after injecting here, marionette lines here. You can end up with ecchymosis. Tell the patient that it can happen. Sometimes you can injure small vessels. If you're unlucky, you can injure facial artery.
What is this size cannula, please?
25 kg. For the other side, I again use the lower port, 18 gauge needle for the port. Also, to lift the lower lip a little, I approach. You should be a little bit superficial here. Not to enter into the mouth, also not to injure the depressor angularis muscle here. It is here. Depressor angularis muscle. You should be a little bit superficial. Also for the nasolabial fold. This is the before and after of the patient. Very good result in terms of nasolabial folds. This is for the Miller injection. Now I'll show the Hinderers lines. For rule of thumb for me in Miller projection injections for fat or for calcium hydroxyapatite, I use the first line is almost horizontal between the tragus of the ear, also near the alanazi of the nose, the almost horizontal line. Second line is passing from the lateral tail of the brow, the lateral canthus, and at the lateral corner of the mouth or modulus, what you call. So there is an intersection of triangle between two lines. This is a triangle. So this is the part in every patient, if the patient is anatomically not very drenched, suitable place for injecting and getting good malar projection in every patient. I always obey and keep to this rule as a rule of thumb. These are called Hinderers lines, famous German plastic surgeon who lived in Spain for a long time. So also, this patient is under infraorbital nerve block. For the lateral entries, you have to inject a little local anesthesia to here, 0.1 or 0.2 ml to introduce the cannulas inside. I almost always use cannulas to inject over the periosteum by lateral entry. You can also enter from the nasolabial fold and inject upwards. Be careful at the mid-pupillary line. You can injure infraorbital nerve 1 centimeter below the orbital rim. It is located here, but the cannula goes here. So I am far from the infraorbital neurovascular bundle and nerve. When you inject from the infraorbital region, you can enter from here or from here, you go obliquely. So I always try to fill in this triangle, and calcium hydroxyapatite fillers, also Facetem, are easy to mold. You will see the difference now. Now you see, good malar projection. When you compare with the uninjected left side, right side, you see the prominence, and you compare. This is the immediate result. You can have several other rules, but I have drawn inner lines on the patient's face again, and now I am injecting just inside the tip of the triangle here. When you inject informally very close to the eye, you can end up with whitish skin colored pigmentations, so it will be a problem. I recommend you not to inject very close to the lower eyelids, also just over the bone, don't do it. Also this teardrop area, it is contraindicated, don't inject. Please only use hyaluronic acid with lower G prime value and without any problem you will end up. So again, threading technique. It's nice that with calcium hydroxyapatite Facetem, you are able to mold. It's not that much thick as you think. It's not that thick. You see the bell projection gain after injection, elevated cheeks, and almost effaced nasolabial folds and elevated cheeks. So the same patient before and after. So this is another patient who ended up with whitish lines informally. So I got rid of these whitish lines, I was lucky, let me say, with cortisone injections, 2 sessions, but do not come closer to the infraorbital region. You see immediately after result, everything looks perfect, but after approximately 1 month, she came back with whitish lines. So these are because of I have injected cortisone here. I was able to get rid of whitish xanthochromatosis reactions, xanthelasmatic reactions, I'm sorry. So mainly chin for chin augmentation, you will enjoy the success of Facetem in the chin region, in the jawline region. My rule of thumb, like Hinder's lines, is Ricketts line. You have to pay attention laterally to the patient's anatomy. You see, these are the different types of anatomy, but if you draw a line from the tip of the nose to the most prominent part of the gonion or the chin, it should touch the lower lip, it should not touch the upper lip, and there should not be space between the line and the chin, gonion. If there is some, let's say, space between the chin, most projected point of the chin and between the line, then you can say that the patient has a deficiency of the chin volume, chinese volume, or she maybe, if there is too much retroconnectia, she can end up with craniofacial surgery. But with chin fillers like Facetem, you can get very good results. So this is needle injection. The patient is under mental nerve block. But let me warn you, if you inject here approximately 1 centimeter below the corner of the mouth, this is the mid-pupillary line, vertically, it's here. If you inject very small amounts to the mental nerve, approximately it is usually 4 to 7 branches, you touch the bone and inject 1 ml, all the hemichin will be, you see the projection, all this area will be numb. Please inject also a little to the midline. And approximately, if the patient has too much deficiency, 1.5 ml to the, you inject over the periosteum will be enough to get good projection. You see the patient? If you draw a Ricketts line, the lower lip and also the chin is back.
So doctor, for the chin areas, you will use needles.
For the chin area, if I inject it on the chin, I use needles. But there is another way. Let me show you.
That's what I
You
want.
can enter from the lateral side here, because this is the edge of masseter, facial artery and nerve is here. So you enter from here, from the perijaw area with the cannulas. You can come from lateral to medial, centripetal. You can inject to the chin area with the cannulas with safety and over the bone, deep. You have to go under the muscles. If you try to go piercing the muscles, it can go somehow paralyzed and it will be painful. But this is the edge of masseter muscle. Let me tell you, if you inject over the jawline area, you have to be superficial because there are dangers. Sorry. Yeah, this is the other part. There are dangers behind the masseter muscle. You can pierce the parotid gland. You can end up with mucous kiss. You can injure masseter muscle. And just at the edge of masseter muscle with the bone, there is facial artery and nerve here, and coming to the surface and coming to near the modulus of the mouth, and coming upwards under the nasolabial fold. In 60% of the patients, then here it is very superficial, then it is converted into the angular artery. So here cannula superficial, here cannula deep.
One of the very common requests by our population here is what they call it Texas. Everybody here wants that Texas. Although I think now it's not as popular as before, but at one time everybody wanted to look that deep, prominent. So what would be the advantage of this material compared to hyaluronic acid?
There are two aspects. For example, to get a good effect for jawline definition, for example, Texas jaw, you have to inject more hyaluronic acid, maybe 2 ml to each side. And hyaluronic acid has a low G prime. It means it has low volumization and low lifting effect. And it will fade away after 6 to 9 months, usually. Sometimes it lasts 12 months. But with the calcium hydroxyapatite volumization and lifting effect, and it is very natural product, and you will use the half amount. As a doctor, it is a little bit more expensive than hyaluronic acid, but it is more rewarding. So it's better to use calcium hydroxyapatite for jawline definition. But in this area, you have to be careful and superficial. You have to inject superficially, not intradermally, but below the deep dermis and in subcutaneous tissue. So you should not see the papules when you inject. Secondly, for now, Texas jaws, I think it's lost and waxed and veined, because from my point of view, I want to create oval faces. If you expand the jaws, it becomes a male face, male jaw. And it is masculinization of the female face. I think this is unnatural. I always opt for natural results in my patients. Also, for the female patients, the chin should be pointed sharp and it should end up with oval face. To get this, I sometimes also, after injection of filler, Facetem filler to the jawline, I inject, for example, to get rid of excess mass here, masseter botulinum toxin injections, to get rid of masseter bulk here, to decrease the masseter bulk, let me tell.
Okay, something coming across the molding. For how long can we mold the calcium hydroxyapatite compared to the hyaluronic acid? I think hyaluronic acid, you can still mold it for long, after many weeks, many days. Up to a week, you can still mold it. How about hydroxyapatite?
Approximately, and also clinically for 1 month, but theoretically 6 to 8 months. What happens after 6 to 8 months? Carboxymetal cellulose component of the Facetem or any calcium hydroxyapatite component is dissolved.
No,
and it starts to replace by collagen. So you can mold immediately, or you can mold in the following 2 or 3 weeks. It's so easy.
Maybe after 3 weeks you can still mold.
Sure, you can mold. It's not solid, or it's not something like, the cement. It's very soft product. Don't worry about this. Also, if you dilute it, it will be softer.
See, when we start mixing in the syringes, and we see how the column of calcium hydroxyapatite, we feel like it's a cement. That's why molding up to 3 weeks is an advantage. It's still there.
Sure, of course. Also, I will show you in the dilution section, sometimes some of you who are using calcium hydroxide will find it difficult to mix from one syringe to other, or from the original syringe to the 10 cc syringe. So I push all of them into a 10 cc syringe, I will show. Then I put two 10 centimeter syringes with good pressure. You can easily, with 15 to 20 passes, you can easily mix it. So it's a little bit difficult to mix it with the original syringe, with 5 or 10 cc syringes. Because, why? From my experience, I think that this is a little bit thicker than radius. A little bit thicker in consistency, IG prime. So this is another case for chin augmentation. Also the patient's chin is injected. I have done mental nerve blocks. Tell the patient that in the following 2 to 4 hours she can feel the lower lip numb. Also, she will be unable to elevate the lower lip, so she should not drink or eat anything or fill her mouth with too much food or drinks, because it can snooze. It can cause drooling also. In these parts, I am trying to inject over the periosteum level. In these lateral parts, I am mainly injecting in the subcutaneous tissue, but in the central part, I am injecting over the bone. While I inject, the patient will feel pain a little afterwards because you are piercing through the mental muscle here in the middle. It's a horizontal muscle. Depressor angularis is the oblique muscle at the corners. It's a little bit far. You pierce the mental muscle. You see the projection? And let me warn you, there is a mental groove here. To fill the groove, you have to inject superficially. It's better to use hyaluronic acid and also a little bit diluted calcium hydroxyapatite. In one of my patients, you have to control from the mouth what happens inside. Because it's very close to the mucosa, I better recommend you not to inject if you're not very well experienced. You use cannulas, but you have to check them out. One of the patients whom I injected calcium hydroxyapatite came back to me after 3 weeks, and when I reverted the mouth, it was whitish. There is some migration here. So don't inject. But I don't see this migration. Frankly, I don't see migration with this polycarpal fillers. I'm also trained on polycarpal fillers, but with calcium hydroxyapatite there was whitish. So it took approximately 3 to 4 months to get rid of this. So be careful about this. So this patient, before and after. I do not inject sodium thiosulfite here inside the mucosa. I inject 3 or 4 times. For example, high amounts, for example, 5 to 10 cc, just direct over it, sterile saline. The aim is to disperse. You know lime that has been used in, for example, constructions lime. If you add water to lime, lime dissolves. Think of it as somehow lime. So this nice projection. But I tell the patients, for example, if the chin is very retruded, if they do not want surgery or implant here, I tell the patients that it will not be corrected in one session, because if you inject, for example, more than, for example, 3 cc, I survived this in polycarpal fillers. I injected 4 cc, the patient was coming from abroad, and I wanted to make quick money, but there was some ischemia due to swelling and also pressure of the filler. So do not inject more than 3 cc or more than 5 or 6 cc of fat to chin area. It will cause pressure, ischemia, and after 3 to 4 days, ischemia was over, but I was a little bit wet about thinking about this patient. I sweated a lot. So do it in different sessions. Inject, then after 6 to 9 months, call back the patient and inject more. But do not try to inject everything in one session. So this is another patient with chin augmentation. I again draw the lines. So this is a cannula, shorter one, you can easily use. This is from center to lateral size to improve the chin appearance. Here I go touch the periosteum and try to feel over the periosteum. But I will show you the later complications part. You have to be careful at the lateral sides of the chin because there are branches of submental arteries, small branches, but you will end up with ecchymosis here. You have to be careful. And while injecting, always try to push the chin upwards to prevent filler migration here. So the result of the patient before and after. The patient will come after 6 months to me. So we will do another injection apart for increasing the chin projection. This is a difficult case because she is a little bit, let's say, she has a little bit overweight, not fat but overweight. The scope, it is evident from the neck. You look at the angle of the neck, it is over 115 degrees. Again with needle. So in this patient there is something particular why I injected to the nasolabial folds, I injected hyaluronic acid. Why I inject to the chin the calcium hydroxyapatite containing filler, Facetem filler. Why? Because this patient has a different, from my point of view, tricky situation. She had completed oncological treatment 6 months ago. So I'm always afraid in these patients because there are immunological changes, alterations in these patients. So swelling is more in these patients, more than normal. So you can end up with allergic reactions, other reactions, because after chemotherapies, you can see unusual reactions in those patients. So I always opted for natural and, let's say, relatively safer products. Nothing is 100% safe, but Facetem is a biocompatible filler. It has very, very low risk of complications and allergy, and also hyaluronic acid that are used to be on the safe side. So before and after of this patient, you see the relatively lower neckline, neck angle here. This is the submental fat. She is losing weight. But if she wants immediate effect, you can inject also deoxycholic acid to get rid of this, as long as she doesn't want to undergo liposuction here for the edge, but she doesn't want to undergo liposuction because she already underwent breast surgery, breast cancer surgery months ago, and also she underwent completed chemotherapy, so she doesn't want any surgery. So this is before and after of the same patient. You see the perioral areas. These are all filled with Facetem filler, total 1.5 mm. This is again another chin augmentation. Let me show the line in this patient again. Rickets line, and you see there is a gap. So we are trying to fill this gap for augmenting the gonium tip of the chin projection. Again, needle or cannula, none of them are precise. You can opt any of them, but in several areas, cannula lowers the risk of injuring the vessels, also vessel embolization. You should inject with low pressure, you should inject slowly, and you should inject, you all know, but I repeat, you should inject in low amounts. And while you are injecting, if there is a problem with the injecting interfering, do not try to increase your force of injection. Retrieve the syringe and inject closer to a closer place, then distribute the filler. So slow injection, aspiration test, in every filler injections with the needle is good for safety, safety of the patient. So chin augmentation, you see very good result here. And also this patient will come again for another injection within 6 to 9 months. So layer by layer we are trying to improve the chin projection.
Victor, one more question is, we had lots of patients in Saudi Arabia and the GCC area who had permanent fillers. They were done at one stage, permanent fillers were were injected in many patients, and they really suffered. What do you feel about injecting calcium hydroxyapatite next to patients who had previous permanent fillers?
From my point of view, let me tell you, do not never use permanent fillers. A Brazilian plastic surgeon colleague in a meeting at Brazil told me, he was of advice, he told me, permanent solutions cause permanent problems. So never use silicone, coming another permanent fillers in every part of the body, in every part of the face. Even for too much money, no, don't do it, because you will be relative with the patient, because she will come again and again. If you are lucky, she will come after 2 years or 3 years. If you are lucky, it will not end up with complications. But from my point of view, I do not inject any filler if the patient is previously injected with permanent fillers in the same area, never ever. Because the patient, frankly I am telling you, as an office worker in private practice, the patient will forget the previous doctor, and you will have the patient in your office all the time. Previous doctor will be relaxing in his office, oh, okay, everything is fine. He has injected permanent filler, and the patient will come to you every time for the semi-permanent or hyaluronic acid filler you injected for the problems related to permanent fillers. So avoid these patients, say that it is okay, it's beyond my realm, it is made a surgery, but it is very, very difficult to get rid of these complications in these patients. So even with the highest money, for example, I don't know, with the highest amount of money, please reject these patients. Do not accept these patients. For lifetime, you will have disasters. Also, never inject, because it will cause inflammation, it can cause chemical interactions, anything. It is something like mud Vietnam. Vietnam War, like. So this is another chin augmentation. I again wanted to show you the gap necessary according to the Ricketts line. You all know, maybe you're a little bit bored with the chin injections. Now we'll proceed to hand injections and also body injections. I'm a plastic surgeon. In fact, I don't like body injections, but in one patient, she didn't want fat injection. But for other places, for buttock and for breast augmentation, also for calf augmentation, I use fat only. I do not like to use, for example, fillers with great amounts in the body or for the buttocks. I think it is senseless. This is a different situation. This patient has icebox acne scars. We are trying to open up these acne scars. These are let's say, adherence of the skin to the deep surfaces. So I mark every scar, then I inject local anesthesia first. With the needle, I try to dissect, needle dissection, I try to dissect the adherence of the skin to the deep tissues, so deep subcutaneous tissues. I dissect with the needle. In such patients, you have to make a good preparation, because if the patient is receiving anticoagulant drugs which impairs blood coagulation, you have to seize it. Because if you do too much dissections, you will end up in ecchymosis. It will be over, but you have to prepare the patient before doing this injection. So in these patients, you will get a very, very good result. I don't have a long-term result, but in these patients, cheeks shine, and these icepick scars, acne scars have been all gone. So this patient has a skinny and also even surfaced cheek now, so you will get very good results. So for hand rejuvenation, for the last two parts, you have to pay attention to the patient's scale. These are very important. There are Merz scales and also 5-point hand grading scale, which is also done with Alistair Carruthers, famous Canadian doctors, for botulinum toxin injections, also for fillers. So for a patient who has very skinny hand dorsal, loss of fat tissue, also visibility of tendons and veins have increased. If the patient accepts fat injection is not better, you get a very satisfactory and puffy hand. But if the patient does not want liposuction and fat injection in the same session, so you can use calcium hydroxyapatite Facetem filler with dilution in rejuvenation of the hand. So the injection plane is very important. There are 3 or 4 laminas. You have to be superficial while you are injecting. It is so easy to enter to the plane. You can enter from the dorsum of the hand, just on the plane at the extensor retinaculum plane. You can sometimes use one hole with the cannula. Always use the cannula in patients to reach the metacarpophalangeal joints. Never pass beyond metacarpophalangeal joints. Stop here. Do not try to inject to the fingers. It is very, very dangerous. Over the one there is extensor tendons. Below there is flexor tendons. And at the lateral side of the fingers, there are neurovascular bundles. Never, never pass beyond the metacarpophalangeal joints. You can inject this area also until this metacarpophalangeal joint. You can inject, and in the extensor borders of the lateral borders and dorsal borders of the extensor retinaculum, you can inject. Also here. But you should inject to the superficial subcutaneous tissue plane, never go deeper, and you will have to use in every patient, if the patient comes, tell the patient that 1.5 ml for each hand may be enough. When you dilute it with 1:1, but you can also make 1 to 2 dilution, it is okay, you can get more products. But also I want to give you a trick. If you are not satisfied with 1 to 1 dilution with 1.5 ml of Facetem in each hand or in any calcium hydroxyapatite filler, you can supply or reinforce the result with LCTC, liquid hyaluronic acid, or with the xDNA. You try to get puffy hands in that. It should be puffy, then it will be over. Then, before I forget, I must tell the patient to wear not wear gloves which are not tight. It's very important. Also you have to wrap the hand, but it should not be very tight.
2 questions actually. How many people do the hand? Calcium hydroxyapatite. Okay. How do you massage the hand? Do you massage with the fingers or what? Okay. I have one advice for you. Sorry for this because I just remembered. Especially ladies. Ladies' wrist ligaments, they are supple. So whenever I do massage the hand, I always make the patient make the strongest fist. الأربطة في معصم اليد في النساء خاصة ضعيفة جدا. أحيانا لما نجي نسوي لها مساج تسمع طقة. الطقة هذه ترى ممكن تسبب ألم شديد جدا مزمن مع فترات طويلة عند النساء خاصة. طيب فدائما إذا حتسوي مساج for the hand especially for the ladies خلي المريضة نفسها تحمي نفسها إنها تسوي أقوى فست وبعدين مساجد as much as you want. Okay? هذه جدا مهمة. الحالة الثانية, my question to you please, would you mix at the same time calcium hydroxyapatite with hyaluronic acid and massage it?
Of course. Of course.
How many people do this?
Of course. There will be no problem.
Very few people will do that.
You can do.
This is a very nice one because it decreases the...
It increases the volume, and you have to try to get a puffy hand evenly distributed buff hand when the piston is like this. Also check for cooling of the fillers. You have to mold it and distribute it before the patient goes home, because later you might end up with nodules.
Which one would you inject first? If you're going to do it at the same time, would you inject the hyaluronic acid first or the calcium hydroxide?
First I inject Facetem, calcium hydroxide.
That's very important, yeah.
Then you inject, for example, look at the dorsum of the hand. Several parts of the hand will be, let's say, depressed. There will be some hollows. Then fill the hollows with calcium hyaluronic acid. Hyaluronic acid, you will have no problem. Don't worry. Also, you can inject liquid hyaluronic acid used in mesotherapy. Also, you can use XDNA. But XDNA causes a little bit fibrosis. Be careful. I have tried all of them. XDNA, someone, fish DNA is injected. Also, is injected to the face. There will be no problems to mix it. You will not have any immunological reaction, no problems. But XDNA, fish, can cause a little bit fibrosis at the dorsum of the hand. But with hyaluronic acid, no problem. For example, total of 3 ml for 2 hands. Also, you can inject 2 ml, total 5 ml to both hands, distribute, no problem.
How about the fingers? Who would inject the calcium hydroxide in the fingers?
Never.
Why?
Very risky, I think.
Yeah, I think this is a very high risk area, and that's why you have to define, when we talk about the hand, we talk about the dorsum of the hands. You may inject calcium hydroxide freely in the fingers, that's okay, but calcium hydroxide, you can inject hyaluronic acid in the dorsum of the fingers, but please avoid it as much as we hear from the professors and the doctors internationally that calcium hydroxide is not preferred. No, not dangerous, because the possibility of any nodules in the dorsum of the finger will be very obvious. And then you can start working on it, and it's very difficult actually to deal with. That's right. Any other reasons why not in the fingers?
Or you can injure dangerous and very important anatomical structures. You can injure tendons, extensor tendons.
That's another reason. My own reason is only because if there is any nodules that's going to stay for a long time, it's a very thin area and always very obvious, very noticeable, I would say. If you would like to say it's because of dangerousness, it's not obvious.
Also, similarly, let me tell you a story. Years ago, when calcium hydroxide was started to be used by doctors in the United States, it was injected to the lips. And the lips has 16% nodules. And they searched why it happens in the lips, because of the movement. So, finger movement and nodules. It collects, it accumulates in several parts of the fingers. The similar mechanism. Wherever there is movement, it accumulates in some parts of the organ, wherever. So you have to be careful.
Okay, Prof, I want to ask you a question, please. No hard feelings. What is your worst case with calcium hydroxide?
Let me tell you, worst case from my point of view was, I didn't encounter any ischemia. I'm frank, alhamdulillah, I pray. No ischemia, no, God save me, no visual disturbances. But only I had nodules in the dorsum of the hand when I injected too much in one area. You have to distribute it evenly in lines, threads, small amounts. If you inject too much at one point, you will end up with nodules. Also, this infection, let me tell you all know, but antiseptic usage, for example, I use chlorhexidine. It's very, very important. If you do not do antisepsis very well, you can end up with granulomas.
Okay.
With biofilm.
So this is what I wanted to raise actually. I'm
sorry
that you mentioned sterilization.
Pseudoxanthilesma reactions in the infraorbital area.
Yeah. What I wanted you to raise that for infection, although I didn't have any infection with calcium hydroxide, but please deal with it as an implant. Infection of calcium hydroxide. If it happens, it's not fun. That's one thing. Now, in terms of the calcium hydroxide and the dorsum of the hand, the first person who ever taught me calcium hydroxide, he used the bolus technique, which I did not like it because we as hand surgeons, we know the hand is not just a balloon that you can put one bolus in some area and you can spread it equally. It's not like that. So dorsum of the hand, it's very important. Although we might look as if it is one balloon, you just fill up and it can expand. No, dorsum of the hand is different septi, different rooms, different path, different channels. So it has to be injected in these multiple passes for the difference in anatomy in the hand. In the hand, you cannot mold one spot from here. It's not going to go to the side. It's not going to go because you have a lot of septi. If you're going to push that hard, you're going to cause a lot of hematoma and bruises and ecchymosis, and it's not going to move. So it's very essential that dorsum of the hand to be injected in multiple passes.
Okay. So this is all also, this part is shown with the start, the injection plane, superficial plane. There are 3 laminas. You have to inject to the upper compartment to be on the safe side. So choices for hand rejuvenation is surgical and non-surgical. If the patient is very old and she accepts, I recommend the patient to undergo fat injection as a plastic surgeon. I do fat injections for it, and to create, for example, I use approximately 15 to 20 cc of fat maximum for each hand. You should not fill the hand with too much fat. It's very dangerous. You can end up with compression. So for non-surgical treatment, you can use calcium hydroxyapatite Facetem filler with very good success. So you can think needle versus cannula. I prefer cannula. It is wiser and safer, almost 100% safer than needles. With needles, you can end up with pooling, I call collection of filler in one area. You end up with too many piercing the skin areas. You pierce and you make many holes. You are very likely to injure vessels with needles. You have to do the pinching technique in every area. You cannot be that much precise. So it's better, and according to this very valuable article, Sidney Coleman, he is a pioneer of fat injections in our plastic surgery field. Use of blood canal instead of needle, this is his statement. For injection into the subdermal plane of the hand, superficial to the veins, minimizes the risk of injury to the blood vessels and nerves.
Sorry, but this picture says as if it is undiluted, isn't it?
Undiluted, yes. But this is not about Facetem injection. Never inject without dilution.
So maybe you can say that this picture is not to do.
Sure. So as a rule of thumb, think where the skin is thin, please thin the filler. Where the skin is thin, 1 to 2 or 1 to 3, you can make the dilute the filler thinner. So if the skin is thicker, you don't need to dilute. But if the skin is thin the filler. So dilution, there are several consensus.
Sorry, doctor, before we go to the hand, I do fat injection towards some of the feet. Would you, if somebody come and request calcium hydroxide dorsum of the foot, would you inject it?
I'm an old school. I belong to old school. I will inject because I want to read the article. I want to see the results. I don't dare to, treat the patients like experiments. So after I have seen good results from my colleagues, or after I have seen good results in the articles, I use it. I never try anything on the patients myself. Because I'm not a Leonardo da Vinci or I'm not a inventor. I always try to be on the safe side. I always try to walk on the other accepted and proven path of the pioneers, from my point of view.
That was the aim of my question, is to give the warning.
Yeah, it's very important. But I did knee rejuvenation with very good results. It can be tried, but do not try to inject too much just over the patella bone. If you inject too much, the number of vessels are less. So I saw a patient who was injected too much, whole area was necrotic. Be careful. Do not inject over the patella bone too much. So deletion of calcium hydroxyapatite is an important fact for dermal remodeling, collagen stimulation and elastic stimulation and skin tightening effect. It is somehow rejuvenation of the skin, also it's somehow like a skin booster. You can use Facetem with very good success. So these are very key and also consensus articles about dilution of calcium hydroxyapatite in any brand you use. it's better to read these articles. There are very good guidelines in these articles. I have chosen this guideline, where to use, how much to use, for example. For the normal skin, 1 to 2 dilution maximum. For the normal, also 1 to 3 dilution can be done. For thinner skin, 1 to 4 dilution. For the atrophic skin, you can use 1 to 5 or 1 to 6 dilutions. But dilution of calcium hydroxyapatite more than 1 to 1 should not be expected to provide volume to face or hands. So if you dilute the filler, you will lose volume and you will, not totally but partially, the lifting and volumization effect will decrease.
Now, as you mentioned, there is atrophic skin. So, in patients who are, their hand is very atrophic skin, and they like the result, but they want more. After how long would you go and inject again?
I will usually, again, I go to the hospital, I will wait 3 months at least.
So, this is one of the differences between hyaluronic acid and calcium hydroxyapatite, is that it's less likely that you're going to go and inject again within less than 3 months. But I think minimum is 3 months. That's very rigid rule. Because if you go and inject any sooner than 3 months, the possibility of nodules and hardness is higher.
Sure.
That's what we're doing. Yeah, this is disadvantage in terms of hyaluronic acid. If you inject hyaluronic acid, you can easily repeat after 4 weeks if you want, if there is no bruise and if you're happy. Mike, please.
Also, from my point of view, if the skin is very atrophic, please send the patient to a plastic surgeon and get the patient injected fat. Because there is 10% adipose-derived stem cells inside the fat tissue for good fat rejuvenation. It is better.
Excuse me, Professor. Regarding, you mentioned before, regarding the anticoagulant, patient should stop anticoagulant before injection, period of injection, how long?
7 to 10 days before.
Okay.
Let me tell you which are aspirin, coumadin, green tea, pomegranate, very, very powerful anticoagulant, pomegranate. Also, let me take garlic, fish oil. These should be all stopped. 7 to 10 days, all anticoagulant drugs should be stopped. Also herbal medicine, because some of the herbal medicine has anticoagulant effect. If the patient is using antihypertensive, I tell the patient to go on using antihypertensive, because in hypertensive patients, when you inject, you will have more ecchymosis and bleeding when you inject to the face or to the hands, wherever you inject. But it is very important. I prepare the patients like I am doing surgery. And if the patient is, for example, using aspirin, but he has to use aspirin, for example. She underwent cardiac surgery, she underwent varice surgery. What should do? We change it to low molecular weight heparin. If the patient is very insistent and you cannot avoid that patient, we change it into, with the consultation with the cardiologist, you change it into low molecular weight heparin, then you do the filler injection with the cannula, blunt cannula, safest way. But tell the patient that, like murmuring, but somehow you might end up with ecchymosis because it's due to your aspirin, so she will forgive you with small ecchymosis. Oops. This video. Now this is dilution, how they do it. So I first retrieve 1.5. This is 1-to-1 dilution, 1.5 ml of local anesthesia. Lidocaine plus epinephrine, or it can be plain lidocaine. Let me tell you, meanwhile, maybe you don't know, but lidocaine has a very, very good anti-staphylococcic and also anti-streptococcic antibacterial effect. When you compare it with antibiotics, 60 or 70% effective against bacteria, lidocaine itself. So it's very important to mix it with sterile saline or with the let's say anesthetic lidocaine. So I retrieved lidocaine, I prepared it. This is Facetem. Let me tell you, it is a little bit thicker in consistency because it has a higher G prime value than radius. It is more powerful. But sometimes, you know, being powerful can be your weakness. You have to control the, let's say, injection, control your filler. You have to know your filler very well. These connectors are very important because in other calcium hydroxyapatite brands, these connectors sometimes cannot resist pressure and you can end up exploding the, let's say I call exploding the filler. You see, I feel some difficulty. You will also feel, yeah. It is a little bit difficult to retrieve. It is easy to push, but a little bit difficult to retrieve. So what I do, I change it into two syringes. I collect all of them in one syringe, in 5 cc syringe. Then I do the passes. Because I see the color of this, it's not homogeneously distributed from my point of view. So to get a better distribution, homogeneous distribution, now I did it with two 5 cc syringes. Then after collecting into this syringe, then I started doing this. Oops. So you followed it, but it is easy when you mix it with two 5 cc syringes. Then you take one of them, then you insert the original syringe, then it is easier. When it is homogeneous distributed, you do 15 to 20 passes. So I have another also dilution, I will show you. How I do, I inject circumferential local anesthesia. Let me show you briefly, not to take your time. I inject lateral border of the hand at the metacarpophalangeal joint line. Then I inject the medial border. Then I inject over the extensor reticulum with a longer dental needle to make one hole in each anesthesia. And through one at the center or through two holes, you can do the hand rejuvenation injection with Facetem or any fillers. You can use one port for entry or two ports. It's so easy. Also tell the patient that after that she will feel a little bit weakness in hand extension and also in hand movements. Then after that, within 2 to 4 hours, this will be over. Then I inject the lidocaine plus epinephrine for shrinking the vessels. Then I wait for approximately 15 to 20 minutes. I offer patient coffee. The patient sits. Then when the hand is almost numb, but tell the patient, ask the patient of her previous dentist experience. In some patients, I call them super patients, the effect of local anesthesia wears off easily. So the patient begins to feel. If the patient is, if the pain is recovering, this is how we do it. If the pain sensation is recovering fast in those patients, please start without waiting. So I use cannulas. I like TSK cannulas. 25G cannulas I like. It's good to use 10 centimeter to 7 to 10 centimeter cannulas because you want to reach to metacarpophalangeal joints through 1 or 2 holes, just at the extensor retinaculum and just at the, let's say, dorsal part of the hand. The length is very, very important in such patients. You see, I measure where I can reach with the cannula. Always use blunt cannulas. I don't recommend you to use needle in the dorsum of the hand. To be more precise, cannula and linear training technique is very, very important. I make a hole, the patient's dorsum of the hand is numb. I make a superficial hole with the 18-gauge needle tip. Then I insert the cannula. Always I try to be superficial and always I try to be parallel to the skin surface and always try to be injecting vertically with the linear threading technique or fanning, let's say. So this is our one-to-one diluted Facetem Now I assemble with the cannula, ESK25 gauge cannula. And let me tell you, after this procedure, it's not very painful for the patient after hand injection. Don't worry about this. So, whenever you feel difficulty, pinch the dorsum of the hand, then go through it. If you feel difficulty to lead the cannulas, retrieve it. Do not use your force to push it forward. First horizontal, then vertical lines. And in some patients who have too much vascularization in the dorsum of the hand, I mark the traces of the vessels, not to injure them. So, I am well below the vessels. And in some very atrophic hands, you have to inject more, let me tell you. You can combine it with hyaluronic acid or with the liquid of NCTC, liquid hyaluronic acid or XDMA. Whenever you have such small lumps, you have to mold it and distribute it with your finger. You can end up with nodules like this. So distribute it with your finger, mold it. And also your injection plane should be horizontal to the patient's dorsum. So this is again dilution of Facetem, one-to-one dilution, because I don't want to lose too much of lifting and also volumization effect. If you dilute more, you will lose volumization. 1.5 ml of Facetem with 1.5 ml of lidocaine. You see, it's a little bit difficult to pull inside to the original syringe because of, I think, pressure difference and also because of consistency of the Facetem filler, a little bit more viscous, high G prime than the original calcium hydroxyapatites, let's say, originally produced in the United States. So what I do is, yes, in the previous case, I changed it to both syringes. It is easier. Pressure is easier. You have to do 15 to 20 passes to homogeneously distribute calcium hydroxyapatite Facetem filler into two syringes. You can ask, what if it does not is not distributed homogeneously? What happens? You know, there is a chamber experiment for fillers. In chamber experiments, if the filler is not homogeneously distributed, then when you inject it into a tissue or into hand, for example, in some part of the hand or tissue, there will be accumulation of more calcium hydroxyapatite. In other parts, it will be more diluted. So you will end up with nodules. Homogeneous distribution is very important. So it's a chamber experiment. Usually they inject, for example, in a chamber full of sterile saline, some filler, for example, it can be calcium hydroxyapatite, it can be polycaprolactone, and they wait for some time for settling of the microspheres in this solution. So it's shown that homogeneous distribution is very important. So again, this area is injected circumferentially, like the hand with local anesthesia, in the subcutaneous tissue, without touching the bone, because there is tibia is more superficial, tibial bone. You inject diluted Facetem filler, and you can get a very good, reasonable result. I try to create as much as possible linear lines with filling, linear threading technique, and also phennic technique. You don't encounter too much of problems. But while you are watching this, for rule of thumb of in all calcium hydroxyapatite fillers for the body, for example, for injecting to the dorsum, for injecting to the let's say buttocks, you have to inject one box of, it means 1.5 ml of calcium hydroxyapatite to 10 centimeters square each. For every 10 centimeters square, you have to inject one box for the body. It is written in the articles, it's not my invention. So it's as a rule of thumb, consensus report says you have to inject 1.5 ml of Facetem or other calcium hydroxyapatite fillers for 10 centimeters squared regions in every part. So before and after in this patient, immediately after, from dorsal side, you see. So, we are returning to the same topic and we are nearing the end. Can it be reversed? These are important articles. If you don't believe me, you can read it. But let me tell you, there are conflicting results. Some of the articles say that I'm a scientist, I'm not a tradesman, let me tell you. Some of the articles say that in very respected articles, it is very effective for dissolving calcium hydroxyapatite accumulations under the skin. But a few articles say that it is ineffective. And also do not inject too much, inject 0.1 to 0.4 ml of sodium thiosulfide, which is 4%, diluted 4% of it, because you can, if you inject superficially, you can end up with skin necrosis. Be careful. So this is an article which backs up, which supports that you can dissolve calcium hydroxyapatite fillers dissolve with sodium thiosulfide. You see the very, very good result. It says it's from Dermatological Surgery magazine. So this is another article which uses sodium thiosulfide for treatment calciphylaxis, calcium and accumulation, especially in end-stage renal failure patients. This calciphylaxis occurs many times, so you can dissolve with calcium hydroxyapatite. These are all very scientific letters. Also, use of intralesional sodium thiosulfide dissolve facial nodules from calcium hydroxyapatite, but these are not related to Facetem, but might be. This does not mean that it does not happen. You inject 0.4 ml sodium thiosulfide, you dilute, and it says that intralesional steroid injections are often ineffective and surgical excision can result in undesirable scarring. So these were treated with intralesional sodium thiosulfide and it's a good alternative. So complications, also there is another hot article which is August 2023, last month. You can find it in Aesthetic Surgery Journal. What is it's a little bit surgical, but under local anesthesia with 1 ml caliber cannulas under local anesthesia. For example, nodules are here. You enter here with 1 ml caliber cannulas. You can do liposuction of these nodules and calcium hydroxyapatite accumulations. It is Aesthetic Surgery Journal 2023 August issue. You can read. It's a little surgical, but it's very effective and it's an American article. You can trust. I trust at least. Now this is a very bad complication. With any filler you can end up with abscess or nasolabial fold. This patient came to me, but this is not related to calcium hydroxyapatite. It is maybe related to hyaluronic acid fillers. With any filler you can encounter. So what I do around the local anesthesia, you don't need to inject because after one injection, abscess is drained. This is 4 days after the filler injection and abscess formation. None of the doctors touch this patient because I have treated many patients like this. Not my patients, unfortunately. Çok şükran. So with one small piercing of the needle, you can drain this abscess. So it is so easy, don't worry, you don't injure anything. Make just one hole because due to inside pressure, it will just explode. And this patient, because there is some hyperpigmentation after 4 days after abscess drainage, tell the patients come every 3 or 4 days because you will have to follow up. In some filler complication patients, please do the follow-up frequently because in some of them, in patients who do not know what they are injected with, it recurs again and again. In one patient, I had to make drainage for 6 months 6 weeks every week, once. So I drained and injected antibiotics inside. I used rifampin. mainly, let me tell you. It's antituberculotic, but against many viruses and bacteria, it's very effective. You can inject antibiotics. I don't inject betadine inside. Even though I inject for the breast prosthesis, I inject betadine, but here I don't inject. So, I think it's a little bit toxic, but it can be a remedy. Because I know that it will, with pressure, it will be easily drained through one hole. But especially in most of the patients does not. You will see. There will be only some hyperpigmentation left because due to inflammation. And this is another patient. This is injected with radius. This is a patient, not my patient, but from a dermatologist, Turkish dermatologist case from Montenegro. For the jawline, she has been injected with radius. What has happened? Submental arteries branches have been injured. So this is the ecchymosis. You see, later picture. This is 1 day after. This is 4 days after. There is some ecchymosis, but without a necrosis. My patient, same is, let's say, patients. So it's resolved, but you have to, what I do, for example, in this patient, if it were hyaluronic acid, I would have injected hyaluronidase to the injected place. Tell the patient to keep his or her elevated. Apply, for example, here nitroglycerin. Also, I start aspirin. Also, I start antibiotics. Also, I inject, for example, 1 to 2 milligrams per kilogram cortisone, one push, great amount to decrease the swelling. Also, in very severely ischemic patients, you can also opt for hyperbaric oxygen treatment. Ecchymosis. I say in extreme cases, what would I do? I'm talking about. Not in this patient. This is not my patient. This is another colleague's patient. So this is another patient. She was injected for maloprojection and her infraorbital artery and neurovascular bundle was damaged according to me, and all this area was ischemic. This is 1 day after, this is 7 days after, this is 14 days after. So with some skin ischemia and with some livedo reticularis, you can, let's say, heal the patient, and afterwards, if the patient has scars, for example, in this patient, I would have started aspirin, cortisone treatments, also superficial, I apply lidocaine containing cream to open up the vessels. Also, if this patient, I think this patient was injected with hyaluronic acid, I would have injected hyaluronidase here, but usually just here, ischemia can happen, which has happened, in fact. Also, necrosis I usually do not expect, but here a little bit livedo still goes on. So the patient also healed very well after approximately 3 weeks. So thank you very much for listening, for taking time for me. If you have any questions, I would like to answer.
Thank you very much. Please take the mic.
We have hyaluronidase as antidote for ischemic complication of hyaluronic acid, but for calcium hydroxide we don't have anything. Except for trying to do vasodilation.
And also, apart from sodium thiosulfate, you can also cause dispersion of this product. I call like a lime, for example, in constructions, you know, lime white. If you inject excessive amount, for example, 5 to 10 cc of saline, stereosaline to the area, it is dispersed. And you can also do some substitution to the nodal area to disperse the product. But you cannot melt it. This is for sure, let me tell you. But you disperse. Sodium thiosulfate also disperses and disintegrates to filler, but it does not melt.
But it may cause superimposing tissue ischemia or maceration.
No, if you inject 5 to 10, it will be, it started to be absorbed within 15 minutes. If you inject saline, don't worry about it. It's also a good test for you, for example, in patients when you have suspect in plastic surgery, if we have suspect, intradermally we inject 1 ml of saline. If it is absorbed within 15 minutes, then it means that the skin is healthy. Inject 1 ml like a mosquito bite intradermally, wait for 15 minutes. If it's absorbed completely, everything is fine. Circulation will be good.
We can discuss some points in our clinical practice with us. For example, you have the hyaluronic and you have also the calcium. I see that you are taking the upper hand to do the volume in the chin or the nasolabial fold with the calcium.
Sure.
So this is your routine use in your clinic, or because you are discussing the material in the...
I'm also using, for example, hyaluronic acid with high G primes in the mother area, nasolabial area with good success. Not in all patients I use. For example, in mass scale, let me tell you, if the grooves lines go deeper, you have to use a lifter, you have to use a, let's say, high G prime filler. So when you inject, for example, for deep grooves, nasolabial folds, if you inject hyaluronic acid, the patient will come after a few days. These are still here, these lines are deep. So you have to use a filler, semi-permanent filler like calcium hydroxyapatite, Facetem filler for example, to lift up the nasolabial folds. So the as the lines are deep, you have to use, for example, a high G prime filler. Or for the temporal region, if their hollows are too much, when you inject hyaluronic acid, you will not get a long-lasting result.
I think so. Most of our colleagues, or nowadays, who are believing that lifting is come from the lateral compartment, not from the nasolabial fold. So, if you want to treat the nasolabial fold, I don't need to use the high prime in the nasolabial. I need to lift from the lateral compartment.
Sure, of course, you have to elevate the malaria.
And I think so. I am believing too that the calcium has the upper hand in lifting in the lateral compartment, maybe more than the hyaluronic acid in some patients. But I didn't see any for injection for your practice in the lateral compartment, and you concentrated to inject the chin and the nasolabial fold. And you see that you have some patients return for you to re-inject the chin with calcium after 6 months. But when we inject the high prime, our filler hyaluronic acid, for example, the Flux or any company, they can stay for more than 18 months. So
hyaluronic acid, you mean?
Yes.
18 months.
Yes, more than. So
which type of hyaluronic acid is too good to be true? Usually,
the Volux,
maximum 12 months.
So the Volux stay for 18 months, and also I can say to CL alternative it can stay for more than that duration. So I think so. You can discuss with us for it is the calcium for volume. There is papers written that its majority action is in volume or lifting.
Majority action is both, let me tell you, volume lifting and collagen stimulation. Third, hyaluronic acid is not good enough for too much collagen stimulation and collagen elastin stimulation. So it has 3 good effects on the face. Hyaluronic acid is weaker in collagen stimulation, weaker in long term, because if you read the articles, first it increases, then it makes a plateau, then it starts to decrease in all hyaluronic acids. But in calcium hydroxyapatite and other semi-permanent fillers, it increases and the plateau is longer. Then after 12 to 18 months, it begins to descend. So in hyaluronic acid, you will easily lose the volume because several patients are also have high percentage of, let's say, hyaluronidase. So you lose the lifting effect more easily.
The last point, you said we cannot inject the calcium in the fingers because it is a movable part, and I think so. The nasolabial fold marionette is a movable too. Yes.
But in the nasolabial fold is movable, but nasolabial fold is there are not, let's say, too many vital structures or anything. You can easily feel it. So there will not be any problem. We are not using this part of the face like our lips or fingers. Otherwise, you would encounter, for example, make a Google search, PubMed search, and see how many nodules in the nasolabial fold related or pertinent to the calcium hydroxyapatite injection. Did you see any? No. You only see the nodules in the lips, you only observe nodules in the mother area, you only observe nodules in the hands. Check if you see, then we talk. So it's not that long.
Excuse me, I'm Dr. Amir Taloush. I want to ask you, I have some repeated cases in my clinics that some of my patients, after maybe 2 up to 3 weeks of the injection, I have swelling.
Which type of finish?
A calcium hydroxyapatite in hands, especially in hands. In your opinion, what is the cause of this phenomenon and how to deal with that?
Swelling in the hands are normal in the first 1 to 3 weeks. This is normal. If you read the articles among, for example, also in my practice, I consider it normal in the first 1 to 3 weeks. Then it will subside, it will decrease.
Yeah, that's what
it will decrease.
Yeah.
It also elevated the hands, also while sleeping in the hands elevated. Also I use anti-inflammatory drugs to decrease the swelling in the patients. Also I tell the patients to wear a little tighter gloves. These gloves can be like, not leather gloves, but cotton gloves. So it will be spread evenly and swelling will decrease. Don't worry about this, it will be subsided.
Good evening. First of all, I would like to thank you for the talk. I'm Dr. Lewis Khas from the Hospital Consulting Clinics. I want to ask you about your experience in the hybrid filler. So you mentioned that you use usually the calcium hydroxyapatite and hyaluronic acid, but not together, not mixing together. I want to ask you about your experience in hybrid filler, which I mean like mixing calcium hydroxyapatite with the hyaluronic acid.
I do not mix it for the hands, you mean?
In general.
I do not mix. First I inject calcium hydroxyapatite. In the face, I usually do not use them together. There will be no problem. But in the hands, if I am not satisfied with the calcium hydroxyapatite, because the third or fourth dimension in patient's treatment is money. If the patient says, I can only pay 1 box here, 1 box here, total 3 ml, so what would you do? You have to satisfy the patient.
Yeah.
So, these are not very cheap, but not too expensive. So if you want to add more volume to the dorsal hand, I think it's cheaper from my point of view. Liquid hyaluronic acid or hyaluronic acid you use in mesotherapies, or also some hyaluronic acid is cheaper. I add hyaluronic acid to fill the gaps.
Yeah, the non-cross-linked hyaluronic acid.
Sorry?
The non-cross-linked hyaluronic acid. Which you use it in the non-cross-linked.
Non-cross-linked, yes, non-cross-linked. Also for the infraorbital area, non-cross-linked hyaluronic, always.
Okay, thank you so much.
There is no chemical interaction or anything you can easily use. Also, I have mentioned there is new product from Allergan which combines hyaluronic acid with calcium hydroxyapatite together in one syringe. Calcium hydroxyapatite is low in concentration. Because you have to send the patient home happy. If still after the injection the patient sees grooves here, the patient will not be happy. Then you will have to do extra work to fill this and you have to pay it for yourself. So it means you are losing money. And also finally let me tell you, I forgot, in the long term, in the places where you injected calcium hydroxyapatite, whatever the brand, if you supply in the same place, if you inject hyaluronic acid, it prolongs the stay of calcium hydroxyapatite in the same region. It stays more. This is a scientific article. So it extends, prolongs the, let's say, location of staying under the skin of calcium hydroxyapatite. It is a very good. They work combined very well together. Okay, please.
No more questions. Actually, we have one more thing. Whoever did not ask a question, we're going to ask you a question. So if you don't ask a question, you're not going to ask any questions. Any more questions from anyone? Okay, one more, sure.
To make sure that I understand well, for if we are going to mix hyaluronic acid with calcium hydroxide in rejuvenation, we first fill the gap with hyaluronic
No,
acid.
first hyaluronic acid,
First calcium,
then hyaluronic acid.
for reduction.
For, let's say, touch-ups. Small touch-ups. Also in the same session you can do. In the same session, yes, you can do, not without any problem. As long as the patient's hand is not through the same or with the cannula, you can use liquid or, let's say, with non-porcelain hyaluronic acid to fill.
So usually you use how many milliliters of
1.5 ml calcium hydroxide, 1.5 ml calcium hydroxide, total approximately 1 ml of hyaluronic acid. It can be 2 ml maximum. But usually I don't want to use more than, for example, 1.5 ml for each hand because I don't want to exceed limits. And also in several, for example, presentations, several others, for example, such as Dimaio uses for 5 ml here, 5 ml here. It's not like this. I don't want to have unnatural faces, unnatural hands. Okay. Always I try to be on the safe side. I inject, I tell the patient, come after 6 months if you want, we will inject more. And in some patients I tell directly, you have to undergo fat injection. If the patient rejects, with the fat injection, you will not be 100% satisfied, maybe 70, maybe 80%. This is a deal.
Okay. Regarding calcium hydroxide, the patient will see the final result at the same session or after 2 to 3 weeks when it absorbs more water and...
You have to send the patient with supplements in the same session. It should not be same. The patient, from my point of view, the patient should not see the veins and tendons when she's going on.
Thank you.
This is, let's say, visual judgment.
Dr. Basil Wesh, Dermalite Clinic. I just have a comment about what you said. Everything you said is correct and I believe in it, but the problem that your patients are different from ours. What I mean, especially in the marionette and the nasolabial fold. In our community, I don't recommend to inject it without dilution. The reason because in your community, the patients are patients. If you tell them that this roughness will disappear, they will accept that. In ours, they don't accept. And they will keep calling you, doctor, that the roughness is still there is swelling. So in general, I don't recommend in our community to follow this protocol of injecting without dilution in these two areas, mainly.
But I'm talking, thank you very much for your remarks, but I'm talking about my experience also according to the articles on this topic. And if in the facial area, except the neck, and except the purpose of skin rejuvenation as a booster, they never use dilution in the face, but from the United States or from the Europe, others. So no need. But you can do somehow, for example, inject half the dose, for example, 0.75 ml of calcium hydroxide Facetem to 1 half. Then tell the patient for 2 weeks you can preserve the remnant of the calcium hydroxide exchange dose system without any infection. Tell the patient come after 15 days if you're not satisfied, you inject more. So it will be better. Yeah. But they never use, for example, let me tell you, for cleaning and for volumization, for lifting, they never dilute in the face. I again say, if you dilute, if you have to dilute, don't use calcium hydroxide, use hyaluronic acid. It's a deal. But even with hyaluronic acid, it is hydrophilic, you know. You can end up in swelling also.
Yeah, I told you that what you said, I believe in it totally, but it's just the difference in the quality of the patients between outside and the Arab patients in general, I mean. sometimes we prefer the calcium hydroxyapatite as a collagen stimulator. This is why sometimes we don't use the hyaluronic acid, we use the calcium hydroxyapatite. But what I said, I recommend with dilution in our community, not in yours.
Okay, maybe one dilution it can be plausible.
Why do we need to inject hyaluronic acid if we inject the hand with calcium hydroxide?
Sometimes it's not enough in very atrophic hands. It's not enough.
Why do you increase the amount?
I want to be always on the safe side. This is not that injection. For example, compact you can inject 15 ml with safety, but for calcium hydroxide, I don't want to inject more than 1.5 ml for each hand. It's excessive from my point of view. It can cause compression, other problems. It can cause, when you inject too much, with one-to-one dilution, you can end up with nodules. So it's better to, let's say, somehow complete it with hyaluronic acid. Also for the nasolabial coating, I must tell you, as you asked, I never promised the patient that you will get rid of these lines. The only creature in the world without these lines is monkey. So it is impossible to completely efface the nasolabial coat. If it is deeper, it will be shallow, but the lines will remain edible. I never promise the patient it will go away. And also for you, if it is too deep and the patient does not want any surgery with it, I lift the cheeks. If he doesn't want surgery, then I fill. So the amount of filler you inject will decrease if it is lifted. It's another idea.
If you would like to come just to the final video with the logo was already.
Yeah. Yes.
Okay. At the beginning, I asked them how many people they would use the calcium hydroxyapatite as a filler, as a volume, and they were so little. After this great talk, and because some international speakers, they only give us before and after, and they didn't show us how to. So really, thank you very much for this. I would like to make it really give us the honest how to, not only just the show. So really, thank you very much. One more thing. At the moment, who would consider using calcium hydroxyapatite as a volume starting from today? So I'm so glad that now there's more people considering calcium hydroxyapatite. So thanks again. It was a great talk. Thank you very much for your attendance, your participation, and your attendance, and people who asked their questions and shared their tricks and tips and shared the questions with us are so important to us. Thank you all, and thank you very much for Dr. Dinah for coming over, and we hope that you would come more often, and maybe one day you will move to Riyadh.
Inshallah.
Riyadh is where the money is in the next many years.
Allah.
Okay. Thank you very much. Okay, if anybody wants to share a picture, please come. Some of us will be standing here, some of us will be standing from here. Anyone wants to take a picture, they can join, please.
Also, let me tell you that the most common complications are related to fat injections. These are not related to calcium hydroxyapatite.